tonight we have MS NeuroTV, and this is a program that we've been doing once a month way before the pandemic began. All right, so we've been doing MS NeuroTV now for a few years. We used to record all of what we were going to do on MS NeuroTV, and then the clinician, the doctor or the nurse or whoever it was, would then come online the night of the recorded program being played and would be there for questions and answers. But since the pandemic, since everything went virtual, we figured, hey, this would be a great time to turn MS NeuroTV into another virtual program among our other 10 that we are doing each month. You'll hear about that later on. And we're doing it live. So tonight we have a great guest. I'll tell you about her in a minute. This is an MS NeuroTV virtual program online. It is provided by MS Views and News. My name, for those that do not know, is Stuart Schlossman. The C, I'll have to tell you another time. Okay, but yes, I am an MS patient first, and I'm president and founder of MS Views and News. Tonight we are supported by BIOGEN. And I know my guy's a little slow at getting things going here. There we go. See, it says BIOGEN. All right, so BIOGEN is a supporter of tonight's program, and our guest. Our guest for tonight is Dr. Annette Okai, and she is from the Texas area. She doesn't sound like she's from the Texas area, but she is from the Texas area. She is now the medical director at the North Texas Institute of Neurology and Headache. So I try to ask her headache questions, but she didn't. She found that to be a headache, so we did not get too far with that. So I look forward to seeing you all later. And for right now, Dr. Okai, take it away.
Thank you, Stuart. I am so happy to be back here. It's been over a year since I was on MS NeuroTV, just when the pandemic started and we were all looking for answers. So we are well past that period where everything was chaotic and we had no answers to our questions. And now we're back and we're trying to get back on track. So I appreciate the invitation. And tonight, I hope I'm able to impart some knowledge to the participants on here. I am going to talk a little bit about managing the symptoms of MS. My disclaimer is that everything that's listed here is certainly not a comprehensive or exhaustive list. There are a whole lot more, but I chose a few that were more frequent or more common amongst MS patients. And I will take questions at the end, and that will give you an opportunity to also ask questions about things that weren't listed here. So some common MS symptoms that if we survey a majority of patients, what they're going to say is will fall into some category on here. Heat sensitivity is huge, and as Stuart mentioned, I live in Texas. Dallas, Texas is very hot. He's in Florida, it's also very hot, so I hear this a whole lot. But there are some patients that are cold sensitive as well. So while heat insensitive may be more common, cold insensitive can also occur, and heat may not bother some people at all. Fatigue is the second one. Fatigue is very, very common among MS patients, and I will delve a little bit deeper into that as we start. And the next one is spasticity, which will things like spasms and stiffness will fall into that category about under spasticity. One thing that we have come to realize is cognition is also involved. Then urinary symptoms, urinary frequency, urgency, incontinence. Less talked about topic is sexual dysfunction. And this occurs in both women and men when it comes to MS, but it's not something that brought up all the time at the doctor's visit. It's something that has to be asked most of the time, but it does occur, and it occurs at a higher incidence than most people would like to acknowledge. And then we'll speak a little bit about depression overall as we move forward. So let's talk a little bit about heat sensitivity. So heat, how does that affect MS? What exactly is it? So I like to remind patients that think about your nerves as an electrical wire, and the electrical wire have to be insulated to conduct very well. Well, not only does it have to be insulated, but it like a cool environment. And if it warms up, then things are very slow to conduct. And when it's slow to conduct, then your symptoms are more pronounced. So heat sensitivity is really has a direct impact on the nerves that are demyelinated, and I'm sure most of you have heard that phrase. The myelin, which covers the nerve, gets damaged, and that results in demyelination. So heat, what can you do to help heat sensitivity, to combat heat sensitivity? Some helpful tips for you is that try to do most of your important activities in the morning when it's not so hot, when the temperature is slowly rising. Because when it does go to the afternoon, then the rise of temperature is very rapid, and that's when the heat index is at its peak, and then that causes fatigue, a feeling of malaise, and loss of energy. So it's best to prioritize and do those high priority tasks early in the morning. Hydration, hydration, hydration. Hydration is important, and it's important to cool those nerves down. Remember, it needs to be in a cool place, so you need to cool it down. If it's hot outside, make sure you're drinking cool water, ice water. If you have ice packs, you're using that as well. Also, when you're hydrating, think about all the other electrolytes that you lose, like potassium, magnesium. So incorporate things like smoothie, which have those essential nutrients and ions that you need in your daily activity. If you are fortunate to have a pool, make sure you cool the pool before you get in, because the water can also get very hot. Or if you're in a pool program, like in Dallas, we have pool programs here for our patients at different locations. Make sure that you call and inquire about the water temperature and see if the water temperature is cool enough for you and it's not hot enough like they do for the arthritis patients. Lightweight clothing is essential. And if you are someone who works out, try not to work out with high intensity when it's very hot, but do mini workouts, break them out during the day. Grocery shopping is something that's very important for day-to-day activity. And when you're out there going to the grocery store when it's very late, or you're having a whole lot of groceries to bring in, it's very tough. So what I recommend is that those are non-perishables that you can buy in bulk. You buy them in bulk so you don't make as frequent of a trip to the grocery store, and your trips may be shorter and quicker. Caffeine is important to avoid caffeine because it's very dehydrating, and it will just counteract the hydration methods that we do. So 1 cup of coffee in the morning, that's good, 1 to 2, but try not to drink it habitually throughout the day. Our next symptom that we're going to talk about, and I'll take the next slide, please, is fatigue. Now, fatigue is something that affects 90% of MS patients, and that is a high number. Why do MS patients get fatigue? It can talk about the demyelinated nerve, but think if your nerves are demyelinated, they are working overtime to do the same thing that an uninjured nerve does. And sometimes patients say it's often the first symptom that they experience long before they got the official diagnosis. And this can be one of the worst symptoms of MS, because people may look at you and may not see MS written on your physical feature, but they really don't know what's going on inside. And that's very tough, because when your energy is just gone, you feel depleted, your battery is used up, and you just hit the wall and you cannot find that extra push to go through. That can be very debilitating. So it's something that is frequently brought up and addressed frequently in MS patients. Next slide, please. So what are the causes of fatigue? The types of fatigue that MS patients experience: nerve fiber fatigue. I mentioned that, where the nerve works over time just to keep the body moving and try to keep it in a balance. And because it's working over time, the nerve fiber gets fatigued, and you feel that as this fatigue that you have no control over. And that is the primary fatigue of MS. But there are other things that also cause fatigue in MS patients. So when symptoms start to set in, the worst thing that you can do is to become inactive. You start to avoid doing things because you're experiencing symptom. Well, I will tell you to do the opposite, because when you become inactive, then you become weaker and your fatigue become more, and then it can exacerbate all the other symptoms that you're experiencing. So that when there's less activity due to symptoms, it's called deconditioning. And so we need to avoid that and continue to be active. And being active does not mean that you are going to the gym 5 days a week, 2 hours a day. No, it's getting your heart rate up 3 times a week for at least 30 minutes. And that could be walking your neighborhood at a brisk pace if it's feasible to walk, or doing some form of physical activity like yoga, Pilates, like MS Views and News offers weekly. So that's something that's important as well. And then our lifestyle also contributes to fatigue. So I also tell my MS patient, just because you have MS and you feel fatigue does not mean that this is all due to MS. If you are a working individual and work is stressful as it is, there's a whole lot to do at work, then you have to come home and you still have to take care of the family, be a husband, be a wife, be a mother and a father. All of that compressed into one day is very tiring. And so we have to look at work-life balance when it comes to MS fatigue and how that translates into controlling fatigue. I'm going to talk about depression, but depression is a main cause of fatigue in MS patient. And as a healthcare provider, I have to kind of tease out what is due to the mood part of most symptoms and what is due to MS. Because when you're fatigued, you don't want to get out of bed. You wake up tired and you have no energy. It's just this general sense of malaise. And that in itself can make your symptoms worse. So depression can lead to fatigue. Fatigue can be from MS, and when you're depressed, everything is compounded, and that make your symptom more pronounced, and that is not a good combination. Well, I won't blame everything on the patient as what they're doing or not doing. We as providers also contribute to fatigue in patients with some of the medications we prescribe. We give muscle relaxants, which can cause sedation and cause people to feel fatigue. Certain pain medications, certain antidepressant can also induce fatigue. So when someone comes to me with fatigue and there is a main complaint, I also have to look at the medications they're on and determine if some of that is contributing to the symptoms and where can we streamline medication so it's not having an impact on this patient's energy level. Next slide, please. So how do you manage fatigue? Energy conservation, what does that mean? You prioritize your task. You do the important ones first, and while you have energy, choose the time that your energy is at its highest and do your important tasks so that they get done and they are not left for a time when you have nothing left. As I said, regular exercise. What is regular? 30 minutes a day for 3 days a week to get your heart rate up. That is called regular exercise, that is considered regular exercise. You look at your sleep habits. If you're going to bed at 12 o'clock and waking up at 4 a.m., you are not sleeping well. Or if you're waking up constantly due to some other symptoms, you are not sleeping well, and that can cause fatigue. So that has to be looked at. How you eat and what you eat is also important. And then counseling regarding your mood is something that we address. I just said how depression contributes to fatigue in MS patients. That's something to look at as well. Cooling methods, if you're overheated, that can cause fatigue. So we have to think about cooling methods to cool your body down to reduce fatigue. And then looking at medications and streamlining it so that we do not have you on medication that's affecting your fatigue and making your lifestyle not ideal as you want it to be. Next slide, please. The next symptom I am going to mention here is spasticity. And spasticity is a catch term for most of the symptoms MS patients experience. So the stiffness in the back, stiffness in the calves and your hands, that can fall under spasticity. It's all due to the muscle, it's all due to the nerve interaction with the muscle. Having muscle spasms where you feel like you're cramping, that falls under spasticity as well. And when you have spasticity, it can be painful because when your muscles aren't relaxing as they should relax, contract, relax, contract. And when you're always in that contracted state, that causes painful muscle. And that can impact a whole lot of things like your sleep, your mobility, your how long you stand or how long you sit. As I mentioned, it's most common in the legs and the back. Next slide, please. And so when all of these symptoms occur, that impact a whole lot of the daily function of MS patient. That's why it's important that it's managed well. When you're feeling that achiness, that tightness and cramping, mention it to your healthcare provider because there are things that we can do to help reduce spasticity. I like to start with the non-pharmacological part of it, which is physical therapy that include a lot of stretching. So when you stretch, you release some of the contraction. Your muscle isn't always contracted. You have some relaxation, and that releases the tension in your muscles. It's the same thing when you do exercise and you do yoga. After a yoga session, your muscles are all supple because of that release of tension that occurs. So sometimes that's covered by insurance. Sometimes it's offered online, and your healthcare provider can make the referral for you. I also refer people for massages, pool exercises, acupuncture. Those are other ways that we can intervene without bringing medications into the treatment plan. But if we do have to bring medication in, there are several muscle relaxants, including baclofen, tizanidine, diazepam, and Botox, which is approved for MS spasticity, to help relieve some of that. The goal is we don't want permanent contraction going on because, as I said, that can affect mobility, that can affect prolonged sitting or standing, and that affects quality of life as well. Next slide. Cognitive changes, the next symptom that come about. This is one of the most common reasons that MS patients leave the workforce when they have difficulty processing, difficulty learning new information, difficulty retaining information. All of that falls under the cognitive changes that can occur with MS. It can be worsened when someone is fatigued, when someone is depressed, depressed. When there is pain, pain can definitely affect the cognitive function. Word finding difficulty, that's a form of cognitive complaint that I hear most of the time. The word is at the tip of the tongue and it's just hard to bring it out. And there's word substitution, or people are describing things for a certain word when they forget the word. So all of those things fall under cognitive dysfunction. But is it all due to MS? When I hear cognitive complaints, I have to make sure that depression is not driving the cognitive complaints. I have to make sure that fatigue is not making it worse, that pain is not the main issue, that a patient is having all these difficulty focusing. And also general health. What do I mean by that? If you have high blood pressure, diabetes, and other what we call comorbid disabilities that can impact cognition as well. Next slide. So how do you manage cognitive dysfunction? When I see this plate, I love it, but most people don't like my plate because I like seafood and I'm in Texas and this is beef country all the way. And so it's hard when I try to convince people to make the switch to majority of seafood versus beef. So for those in Florida or anyone else near the coast, they understand what I'm saying because this can be a very healthy and delicious dish. But I talk about the causes of cognitive dysfunction. So let's talk about the treatment. If fatigue, if depression, if pain is contributing to the cognitive symptoms, that needs to be treated over time for the patient. Then energy management. So you don't want to overdo it. Then your brain tends to slow down. Sometimes I send my patients for cognitive rehab. They go and get a neuropsychological evaluation and look at the different places in the brain and how they function. And just like if someone had weakness, I would send them for physical therapy. If someone has cognitive changes, they go for cognitive rehab. And that is done through the rehabilitation centers that are around the different areas. Medications, we don't have approved medication for cognitive symptoms caused by MS. We have to remember that this is not dementia. It is due to MS. So the dementia medications, we haven't had the best of luck with them. And then if depression or mood is a problem, we refer them to counseling to help deal with those mood changes and improve their cognitive symptoms. Next slide, please. So the next thing I like to talk about is urinary symptom. This is an invincible symptom of MS. And by the way, most of the symptoms I've been talking about has been invincible. What do I mean by that? If these are things that the outside world cannot see. They cannot see fatigue. They cannot see cognitive changes until it's too late. And urinary symptoms are also invincible. You know, they look at you and you're walking, but they do not see that you have to go to the bathroom every 30 minutes, or you're unable to take long trips, or you have to plan your trips around your bathroom breaks or how many clean bathrooms are on the expressway before you get to your destination. This has a huge impact on quality of life, and this causes social distancing. Then most people will prefer to stay home than go to a restaurant with their family because they don't know what a restroom is and how is it going to be perceived getting to go to the bathroom all the time. The opposite end of that is urinary retention, where difficulty going to the bathroom comes into play. And that is also something that can be done. When patients have severe urinary symptoms, I bring in my colleague, the urologist, to help with that. And they do several testing and see, okay, is this due to muscle spasms in the bladder? Or is it due to weakness of the bladder walls? And for women, could it be because of a history of childbirth and all of that? Is it all MS? We always have to ask that symptom, that question as well. Next slide, please. So what do we do for the urinary symptoms? Well, we want to avoid things that irritate the bladder. So caffeine, alcohol, aspartame. Aspartame is found in most diet drinks and artificial sweeteners, and that can be irritating to the bladder. So we want to avoid that. And this avoiding schedule is important. And the way I explain it to my patients, I say you have to put yourself on the potties. You have to potty train yourself. And they laugh because most of them have had kids and gone through potty training. But it has been proven effective in helping to control urinary frequency, because if you train your bladder to hold urination for an hour, 2 hours at a time, then you have a leeway in planning your social activities. Now they have bladder stimulation, electrical stimulation, then there's medication. But at the extreme, some people will have to do self-catheterization to help control those symptoms of the bladder. But hopefully we can get them to the specialist in time and we can treat and control the MS, that we avoid that as well. Next slide, please. Sexual dysfunction. So what exactly is it, and why don't people like to talk about it? Well, understandably, because if this is something that a patient is struggling with, it also ties into self-esteem. It also ties into mood. But if it's not talked about, then it's not addressed. So what are some of the signs of sexual dysfunction, or what can impact sexual dysfunction? Well, if you're numb in the groin area, that can affect your libido. And sometimes the medications that we give you decrease the libido as well. And sometimes symptoms of MS just make it impossible to have the desire to be intimate with your partner. For men, erectile dysfunction also come into play. And for both men and women, difficulty reaching orgasm is something that I hear a whole lot. And impacting that, fatigue. If you're tired, you really aren't in the mood to be intimate. If you're in pain, some MS patients have skin sensitivity that even touching the skin causes pain. So just the thought of being intimate with someone and having touch all over it can make the libido go down, and that can cause sexual dysfunction. Depression is a recurrent theme on here, can also lead to low sexual response, and I mentioned medication as well. Next slide. Depression. I just mentioned that and how it seemed like a recurrent thing, but depression is the great chameleon. It can masquerade as a whole lot of things. Most people think about depression as you walking around with your head bent and it's shown all over your face. But as we know and as we have seen, there can be people who are smiling, laughing, and being very social and an extrovert and still be depressed. So you have the negative symptom of MS where everything is just down. The mood, the face, the posture, and everything is down. But you can also have other things that camouflage. So depression can masquerade as fatigue. Depression can masquerade as cognitive symptom. Depression can masquerade as sexual dysfunction. So all those, we have to look at all of those things. And then once someone is depressed, it affects other symptoms of MS. And that's why it's always important to treat for it. We ask about it and treat for it. Quality of life, very poor for someone who is depressed. And depression affects more than half the people living with MS. Next slide, please. All right, symptoms of depression. I mentioned that. I said, how is the great chameleon? So we talk about the negative symptom where the patient looks sad, or they have crying spells, everything make them cry. Their mood swings, irritability. They have high anxiety. Depression can affect sleep. It can masquerade as difficulty sleeping or sleeping all the time, 12 hours or more. That's not MS fatigue. Then we have to look at other things. Appetite changes. Some people eat a whole lot when they're depressed. Some people do not eat at all. So the spectrum is very wide. And then there's apathy. They just don't care about what's going on around them. Next slide, please. And when you don't care what's going on around you, then it affects the people around you, your circle, and those that support you. So how do you manage depression? Non-pharmacological intervention. First, counseling. If you feel that if you need counseling, you can talk to your healthcare provider and they can make that referral for you. For some people, just exercising can help improve mood. And what is exercising? After all, remember I mentioned is 3 times a week, and getting your heart rate up is considered regular exercise. And then other forms, meditation, praying, sex. Depression can masquerade as sexual dysfunction, but on the opposite end, if you're intimate with someone, it can also improve your mood overall. And my personal best is chocolate. I think chocolate takes care of everything. That's my motto, but you can't eat it in abundance. But that also, chocolate has a chemical that helps relieve certain pheromones in the brain that helps you improve your well-being. And then you have a group, someone who supports you, and a group that supports you to help improve your mood and get you into that frame of mind. Next slide, please. So, good. So, Stuart, I am going to stop here. Actually, it took just about 30 minutes, so that leaves us another 30 minutes for questions, and I will turn it over to you.
Thank you. That was an excellent talk. I have so many questions from people that have written in, and I have so many more questions that I assembled for you as well, because I just know that there's a need for it. But firstly, I want to thank you. This was an excellent talk. Excellent talk. All right. Actually, one person asked me, where are you from? Because they don't recognize your accent and they want to know where you're from. So can you tell them that, please?
So I don't have a very distinctive accent. It's a mixture. So originally, my family is from Liberia. I was born in Liberia, which is in West Africa. And I live in 2 other countries, and then I now settled in Philadelphia. So it's a mixture of several other places.
Wow, that's great.
Well. Yeah.
That's great. That's great. That's awesome. Thank you very much for that. All right, so let me get into some of these questions. And it's just so much. I can't wait to start asking. All right. So the first one is from a person named Tammy, and Tammy wants to know: is there a neurological or a neuropsychological exam? The only cognitive rehab is a neurological exam the only cognitive rehab that is available?
A neurological exam, the only cognitive rehab. So right. I am not sure where you are, Tammy, but most places you do neuropsychological testing. And then based on the testing, you go to the speech and cognitive rehab falls under speech therapy. So it's not only how you talk, it falls under that category. And then the speech therapist, based on your neuropsychological test results, puts together a program, a cognitive therapy program for you.
Okay, thank you for that. Next,
Yeah.
A. Cindy is asking, do you believe that a particular DMT, of course combined with the right individual, could impact fatigue levels so much that it is so impactful that other symptoms start to disappear? I mean, without any other medication, just the DMT.
That's an interesting question, and I say interesting because everyone is so different and their response to medications are different. The way I would answer that is that certain medications that we use, certain DMT, may cause fatigue. And so when we take you off the medication and put you on a non-fatigue causing medication, then you have a different perspective because now you are not always so tired of fatigue. Now, most of our medications out there will not carry this claim that it improves symptoms or it's going to improve your energy level. But if we are reducing inflammation, which can be a major cause of fatigue with a certain medication, and we're doing it very well, yes, you can see some improvement in fatigue on the medication.
Okay, thank you for that. By the way, I want to let you know before I get into other questions, yes, I'm in Florida and I love fish. Okay.
Yes.
I don't eat beef at all. I haven't eaten beef in an extremely long time, and I just love eating fish. There's plenty of different options that we have here.
Awesome. I'm landlocked in
You're
Dallas.
Landlocked. Well,
Yes.
in Dallas, you're landlocked, but maybe you should get down by Brownsville.
Oh, Galveston.
Or Houston or somewhere over there.
Mm-hmm.
Okay. All right. Next, what happens when you have new symptoms but you don't have markers on your MRI?
Okay, so great, and that's a great question that I think most patients can relate to. They go into the doctor and say, "Doc, I'm having this symptom, and we do an MRI, and I'm like, "Well, your MRI is stable." That is not unusual. That is quite common actually, because not every symptom that you have we're able to see on MRI or it means that you're having a new symptom. Your old injury over time, because we cannot really repair the nerve, we have what we call long-term symptoms. So when you have a lesion forming or you have inflammation at one particular time, you get certain symptoms with that. After the inflammation goes down, after the healing has taken place, then you have new symptoms that crop up in the long term. So just because your MRI does not show any markers of inflammation or anything new doesn't mean that your symptom is not MS related, doesn't mean that it's all in your head, doesn't mean that you are not experiencing a relapse, doesn't mean that you are not experiencing anything new. It's just that at the level that you are experiencing, we cannot view it with what we have. But it is a known fact that people can have worsening or new symptoms without new MRI activity.
Okay,
So
great. Thank you.
It's just treating the symptoms as they occur.
Thank you for that. I just want to apologize to everybody. If my internet looks choppy, I don't know what happened. It was perfect before the talk, and all of a sudden it's like freezing up on me. And that's why I couldn't get back online. It wouldn't let me online before. So sorry about that. All right. Thank you for that last answer. Now, next we have a person is asking, with regard to exercise, does 30 minutes of exercise 3 times per week need to be 30 consecutive minutes, or can you elevate your heart rate for 10 minutes 3 times each day?
I think I will say whatever you are able to tolerate. But I don't think there's a strict guideline to say the 30 minutes have to be all at once. Because I also advise my patients, if you cannot do 30 minutes in the morning, break it up to 15 minutes here and 15 minutes there, 10 minutes here, 10 minutes there. So it doesn't have to be all at once 30 minutes. You can break it up 3 times a day, 2 times a day, however you can tolerate, and that will satisfy the criteria.
Okay, great. Thank you for that. So next we're going to be jumping around here. Is there a certain diet that you recommend for people with MS?
Okay, the question, I get this almost every week, almost every day. And what I counsel my patient is that there isn't a one particular diet that I endorse. When you Google that, there's every you get a whole lot of hits and a whole lot of advice. But what I encourage my patients to do, and I'm going to say the word diet, but really is a lifestyle change, the Mediterranean diet, which it has been proven time and time again to be heart healthy, to promote overall health. So it's the Mediterranean lifestyle that I will recommend, because you have paleo, you have keto, you have a whole lot of other things out there. But when you look at the core of all of those other diets, it starts with the healthy oils, the healthy grains, and all of that. And that's what you have with the Mediterranean lifestyle of eating. So if anything, if I have to say the word diet, I will say the Mediterranean diet. It has been proven over and over to have all the benefits you need for your overall health, including MS. And they did do a study with brain health in the Mediterranean diet in MS, and that was they had a positive outcome as well.
Okay, thank you for that. How do you reduce the burning, numbness, and tingling that people are getting? What do you is there a way for people to, this person writes, turn it down, but I'll say, how do you just reduce it from what you're feeling?
Okay, so I will just put my disclaimer out there. I cannot give personal medical advice, so I will speak generally. So we have, once again, it's a nerve symptom. Your nerve has been damaged and you're getting all these. And it can be very annoying and you just need to turn it down a little. I get the phrase that you're saying. So we have lots of medication options out there that can be prescribed for patients. Another non-prescription medication and supplement that I sometimes recommend for my patient is alpha-lipoic acid. That helps with the numbness and tingling as well. But for the medication part, we have at least a good 4 or 5 options that can be prescribed for your healthcare from your healthcare provider.
Okay, thank you for that. Next, how do you differentiate the difference between spasticity or leg cramps? The person wants to know, how do I, if I have all this pain in my legs, do I call it spasticity or do I call it leg cramps?
No, so as I mentioned before, spasticity is just an overall term, but you can break it down into different things. So if it's cramping, it's leg cramps. Spasticity is just a term we use to catch all of that. And if we put in our notes so that the insurance company will know. But if it's cramping, it's called leg cramping. I'll call it leg cramps.
Okay, so
Yeah.
Going on to similar topics to do with that, the contractions that you spoke about. for me personally, I wake up in the middle of the night often with tremendous pain, where I could be screaming my head off with the amount of pain that it is, and I can't get it to release. And I can't walk. I could barely stand, but I can't be laying down. I've got to get upright right away. What is the best way to try to get that to release? Because trying to do a stretch makes it worse.
Massaging makes it worse as well.
Yes.
So in that situation where it's in the middle of the night and you're in this tremendous pain and it's just tight and all of that, what I normally try to do for my patients is, okay, what is the anti-spasticity medication that they're on? Okay, so most of our spasticity medication has a time period in your body. So is it a short acting one? If it's short acting, then I look to put a long acting medication at night so it keeps them during the night. But if there's breakthrough pain during the night, I give them a short acting one that they can reach to real quick, because you're going to have that intense cramping pain that's not going to go away just after a few seconds. But even after it goes away, it leaves this achiness, and then you have difficulty just falling asleep. So one, you have a short acting medication that you take right away, and then try to massage it until that goes away, and then the medication kicks in, and you don't have the lingering effect of the achiness that came with that horrible pain. But I think primarily is try to give something right before bed that will go for 6 hours, 4 to 6 hours, so you don't have a whole lot of breakthrough in between. That's how I manage it.
Got it. So I find that once I can move to another room and get in like the bathroom, I take out a solution like the BioFreeze or Stop the Pain or something, and just to get some topical medication on, it seems to help reduce the pain, rather quickly, which then makes it very joyous.
Stuart, I should ask you, is it getting the medication on quickly, or the act of getting the medication on quickly, which is in a way massaging that muscle as well?
Correct. Very correct. So what about, all right, next question that leads to this as well. This is not my question, but it does lead. What about medical cannabis for spasticity?
So medical cannabis. So cannabis is, it's the biggest thing, it's been gaining steam throughout. I must say that of everything that we know about cannabis, the two main things for MS patients is that cannabis affects spasticity and pain. Those are the two things that cannabis have been studied for in MS. So it does have a positive effect on symptoms of spasticity and pain for MS patients. So for my patients who have spasticity and pain, I recommend medical cannabis for them. That's another option. For others, they're like, well, Dr. Okai, I have MS. Can I get, medical marijuana? I'm like, okay, what symptoms are you having? I don't have a particular symptom. I have MS. I'm like, well, okay, just because you have MS doesn't mean you go on medical cannabis. But because we have data, there's actually studies that have shown that medical cannabis does relieve spasticity and pain. I do recommend that for patients who experience it.
Great, thank you for that. Okay, next, how to treat, the question is, how do you treat cold sensitivity? And the other question is, how do you treat heat sensitivity?
Okay, heat sensitivity is basically you use cooling vests, you wear light clothes, you keep your body temperature down by hydrating, by drinking cold water, cold drinks to keep the body temperature below a certain one. So mostly internal, and avoiding in the most intense part of the day. So that's how you treat heat sensitivity. We don't have a medical prescription for that. Now, cold sensitivity is a little bit different for most people. What I find in my patients is that people who are cold sensitive are people who experience more spasticity during the winter time, and they just tight ball and feel uncomfortable with any type of coldness. So treating their spasticity and relaxing them during the periods of cold actually improves their symptoms.
Right. That's why I use a heating pad on my legs when it's cold.
Mhm. Yes.
Right. Okay. I had a question to ask you about memory and cognition, but I can't
Mhm.
remember what I forgot.
Oh man. Yeah, typical dilemma.
Typical dilemma. So,
Mhm.
looking further into that typical dilemma, how do you tell the difference between aging for a person with MS and
Mhm.
cognition true to MS? And does it all link together? And where is the fine line difference between a true cognitive issue caused by the MS versus aging and slowness happening in the brain and maybe
Mhm.
a person that's leading toward Alzheimer's or dementia?
Okay, so multiple things. So it takes multiple steps.
That's right.
So when patients come and they're complaining about cognitive symptoms, obviously what to tell me and how I probe or how I ask the question can lead me one way or the other. But where I do start is with during the neurological exam or just even listening to the patient throughout our visit. You're able to pick up things that occur with cognition when you're talking, when I ask them a question. It's like, yeah, Dr. Okai, that thing that we did, and they're looking for the words, I'm also doing the exam at that time. But certain situations and certain circumstances can lead me to say, okay, this sounds more like old age, or this sound more like MS. And then I get to the neurological examination where I ask a few questions. I ask memory tests, questions to remember a few things to help me differentiate with that. But if cognitive is the main thing that the patient is coming through, uh, uh, one screening tool that I use in my office is a cognitive test that takes less
Sure.
than 10 minutes. And inbuilt in that test, you are able to tell what is attention, what is really difficulty connecting the dots. I do a cognitive screen in my office that gives
Sure.
me an idea. But if it's really a concern, then I refer a patient for full neurocognitive testing, which is the 3 to 4 hour test. And that can help to discern between dementia, MS, depression, or just anxiety causing these symptoms, or if pain or anything is contributing to it. So there are different steps and different layers depending on how the complaints are.
Okay. All right, great. Thank you for that. Let's switch topics slightly again. Cindy is asking regarding anti-CD20 mavs, wondering why the routine blood taken prior to receiving the certain medication, DMT, does not test specifically for CD20 counts. CD19, yes, and many other B and T cells are tested. What can you tell us about this?
So short of taking you to immunology class, we normally test for CD19 because it's the marker that is most common on all of these cells that we are targeting. So even though the drug says anti-CD20, we are testing for CD19 because that marker is specific and it's on most of the tests that we want, and it's easily tested. So that's why we do that. It's all
Okay.
because of the markers.
Okay, thank you. So continuing with that, Cindy's asking, Why are B and T cells also evaluated with what's known as natural killers or NK? What really are these NKs?
Natural killer cells. So all of these are cells of your immune system, and they all play a different role in the immune system. And when you have either a decrease in one or the other, you have to have a corresponding increase or decrease as well. So the function of the test and the function of your immune system depends on all of these cells working together to get to where we need them to be. And they all fall under one panel. So you really can test for CD20 specifically and leave out CD19 or natural killer or CD52. They're all just markers on the cells that we look at in looking at the whole immune profile of that person. Okay. I hope that made it clear.
To me, no, but to her, hopefully. Okay. Can you explain antibody-dependent cellular cytotoxicity?
Is there an immunologist on here? Or so those are words, those are phrases or words that we use depending on how the cells are, for lack of a better word, killed. So if we want to get rid of B cell, how do we go about getting rid of B cell? Do we do it through antibodies that are released from certain cells, or do we do it through how another thing is what we put in there, poison? I'm trying to find a good analogy. It's just a method of getting rid of the B cells that give rise to those phrases. So ADCC, which is what this person is trying to say, is one way that one of our treatment get rid of B cells, and then we have another one that use cytotoxic is another phrase, way of getting rid of the cells. It's just mechanism of getting rid of the cells.
Okay, thank you. I have 5 or 6 questions remaining for you.
Okay.
And I know it's getting late. I'm going to ask everybody not to send in any more questions, and let me just get through these remaining ones, and because Dr. Okai's got to go to bed. All right, so do I. Okay, but seriously, it's getting late also, especially here on the East Coast. All right, so the first one is, how do you help patients with an abnormal gait?
Physical therapy, physical therapy, physical therapy. That is important, especially when gait is involved, because we have to keep muscle memory, we have to keep endurance, we have to keep strength. So physical therapy is something that I tell my patients with gait abnormality that you try to order at least twice a year, because you get great benefit from it. But of course, because it's non-invasive, that benefit wanes over time, and then you go for your second booster, as I call it. We're talking about booster with vaccine. I used to talk about booster with physical therapy. So that's the main thing I like to order for my patients. And then, of course, we have, a medication, dalfampridine, that's available for people with gait abnormality, depending if you meet criteria to use it and if you respond to it. That's one thing we can use as well. And then, and depending on what's affecting the gait, if spasticity is affecting the gait, increased tone, treating that is important as well.
Okay, thank you. All right, next, how do you help a patient overly fatigued from depression? You spoke about this before without saying how you would actually help that patient.
Okay, so if the fatigue is caused by depression, it's treating the depression. So if I start off, if it's really depression that the patient is experiencing that I can handle, I will first treat the depression. If the depression requires a specialist, I will refer them to a psychiatrist to help manage that depression. Because once you treat the mood, then the fatigue improves. And I hope that's where that's how I understood the question, unless there was something else.
No, I think that you answered. I would have thought for you to answer it something like treating the depression as well. So I'm hoping we're both on the right wavelength there, okay?
Yeah.
All right. Next, I want to let people know, I mean, you spoke about the bladder issues earlier and about people, traveling a lot. I'm going to suggest that, especially if you're traveling like I-95 or A Turnpike where there's a lot of rest areas, before you get out on the road, you may just want to look on the internet and look up the highway system and see where rest areas are located so you could actually plan and know and not think that you're hours from the next stop when you could be just minutes away, or that you could actually plan and know that I should make a stop. There's a stop coming up. I should make that stop because Lord knows what's going to happen ahead of me. Cows could be out in the middle of the road and you can't get anywhere. And oh my gosh, the bladder's got to go, right? So you may want to have planned stops for yourself. It's just something that I just wanted to let you know. All right. I'm 62 and I have MS, and I definitely plan for all these. And when people see me going on an airplane too often to the bathroom, I look at everybody by the bathroom. I say, I'm 62 and I have MS. If you don't know what that is, look it up, and then you'll understand why I have bladder issues. Okay. Next, a person writes, my neuro claims that I'm not getting worse, but yet now I'm needing a walker where I didn't need one in the past. I live far from any other neurologist. What can I do?
So is it the change in mobility that we're concerned about?
Yeah. So
okay.
I know who it is, and he's saying that his neurologist may have a little bit of tunnel vision and claims that he's not getting any worse. But a couple of years ago, he wasn't in the need of a walker, and now he's in the need of using a walker that he doesn't want to be using. He lives very, very far from any other medical specialists. And what can he do or say to the current doctor?
Okay, so several things come to mind directly. So we have to think about, where we are in the disease process. We have to think about what medication that's on and what intervention has been made. Has physical therapy been done? Recent, if that's something you can ask about and say, can I be referred to physical therapy to help improve my gait because I started to use this device, or balance, gait and balance, let me say that. Or is it spasticity that's also affecting the gait? Then spasticity will also have to be treated, or physical therapy can also help with that as well. Yes, probably a change in therapy may be called for depending on what the patient is on. That's another way to have the conversation and say, I think this medication isn't working for me anymore. Are there any suggestions? What do you think? So there are different ways to look at the same problem, but also we have to realize that, Stuart, you mentioned you're 62 and you have bladder issues, right? So, and you have MS. So at 62, I will also expect a 62-year-old male without MS to have urinary frequency as well, right? So we also have to put that in context to say, is it because you have MS that you are using the bathroom more frequently at 62, or is this something that's common for a 62-year-old man? And I know, Stuart, you don't mind me using you as an example.
Oh my gosh. Oh my
I know.
Is there a HIPAA thing about that? No, I'm joking.
I know. Yeah, so all of those things need to be taken into consideration. And as I said, when it comes to gait, the first thing I think about when there's a change in walking devices, let's do physical therapy first. Then we look at your disease modifying therapy. Can we make a difference if we change disease modifying therapy? If we're not going to make a difference, I'm not going to change. And just all the other things that may affect the gait as well.
Okay, thank you. Before I get to my last question, I have to remark on a remark that the Cindy, who was asking all those tough questions before, has written for you. She would like Dr. Okai to know that she's so appreciative that she answered my questions. That really has helped me understand so much better. And that she also appreciates, Stuart, for having you on this program and putting this all together for us. Thank you, Cindy, as well.
Thank you, Cindy. I'm happy I was able to clarify things for you.
Great. Now, the last question here is similar to your last topic, and that was about sex and MS. Mm-hmm. So the question is, what do you recommend to an MS patient who has lack of feeling in the down theres?
What do I recommend? So this is this
you
is
on the spot now.
Yes. So by no means am I a sex psychologist, but there are sex psychologists out there in a few centers, and I happen to know one who I worked with very closely. So I learned a few things from her to help patients as well. So when there isn't any feeling, now that is a tough part. So for you and your partner, then you have to use the rest of your body to stimulate you and get your mind going, because your mind also has to be involved as well. So you also have to stimulate the mind first, use the rest of the body before you go to the actual intercourse part, so that you are prepared all throughout before the actual act. And that's the best that we can do at this time, given that we have lack of medication for this. So you have to think outside the traditional way of being intimate with your partner to improve the libido and to improve the stimulation before the actual act.
The actual act, yes. So the actual act, I'm going to tell you all, create a nice scenario in your head. There you go. That's all I'm going to say right now. This is PG rated. I'm not going to get into that right now. Okay?
Exactly. Yeah.
Okay. So, Doctor, we went through all the questions. I loved your dialogue tonight. It was fabulous. I would love to have you on again and again and again. So we're going to have to work on that, okay? And MS
I will be happy to be back. Thanks for having me.
And we need to get back to Dallas. Well, yes, we didn't get to Dallas 2 years ago because of that mess that happened, right? So we do, a year and a half ago, we do have to do this, and I do look forward to it as well. All right, so for now, though, we are finished with our questions. We're finished with your dialogue. I do want to say thank you again to you all and to everybody that's online. Please remember to go to our website, check out the event that's happening this Saturday, as well as all the events that are happening over the next several weeks through the end of the year. Okay, there are plenty of programs for you to choose and be part of. All right, thank you very much, Doctor. We'll speak with you again soon. Have a great night, everybody.
Have a great night.
Thank you.